Let's see about malignant melanoma. So, malignant melanoma is a neoplasm of epidermal melanocytes. So, it is a neoplasm of epidermal melanocytes and it is the third most common cancer of the skin. Third most common cancer of the skin. So, malignant melanoma is the neoplasm of epidermal melanocytes. So, cutaneous melanoma is increasing in incidence. So, the frequency of its occurrence is closely associated with the constitutive color of the skin and depends on the geographical zone. In Africans and Asians, the annual incidence rate of malignant neoplasm is only 0.2 to 0.4 per 1 lakh population. So, it is most commonly affecting the palm, soles, and mucous membranes. What are the environmental factors that involve in the malignant melanoma? First one is sun exposure, artificial UV sources, socioeconomic status, fair skin, freckles, red hair, and number of melanocytic nevi. So the first one is sun exposure. The highest incidence of the melanoma has been reported from areas with long hours of sunlight throughout the most of the year. So highest incidence is occur in the where the sun exposure is higher. And artificial UV sources, longer wave artificial UVA may play a part in the etiology of melanoma in addition to exposure to natural sunlight. So sun exposure, and next one is artificial UV sources, and the third one is socioeconomic status. So several studies have been reported that melanoma is more prevalent in those high socioeconomic status. Maybe the fact that the later can better afford holidays in the areas of high UV intensity. That is the reason. So socioeconomic status, high socioeconomic status is the most common reason. And the fourth one is fair skin, freckles, and red hair. These are the phenotypic characteristics in increase the risk of melanoma. And the fifth one is number of melanocytic nevi. So the total number of melanocytic nevi, dysplastic or bland, has been reported by several groups as a strong risk factor. So these are the environmental factors that involve in the malignant melanoma. Sun exposure, artificial UV sources, socioeconomic status, fair skin, freckles, and red hair, and number of melanocytic nevi. And what are the genetic factors? The first one is familial melanoma and the second one is xeroderma pigmentosum. So in familial melanoma, it occurs 2 to 5% of melanoma patients have positive family history of melanoma in at least one first degree relative. So 30% of melanoma patients abnormalities on chromosome 9p21 are seen. So it is very important. The affected chromosome is 9p21. So it is very, very important. And the second one is xeroderma pigmentosum. So genetically determined disorder and defective DNA repair mechanisms lead to excessive chronic UV damage and subsequent development of different sun-related skin tumors including melanoma in sun-exposed areas. So xeroderma pigmentosum is a genetically determined disorder. There is a defective DNA repair mechanism. So the genes implicated in the development of melanoma are CDKN2A P16 and CDK4 chromosome 12 Q15 and RB1 CDKN2A P19 and PTEN or MMAC1 and ROS. So here the important gene is CDKN2A, that is P16. What are the risk factors? So the risk factors are unknown. So cutaneous melanoma, it has two phases in the growth of melanoma. One is radial growth phase and second one is vertical growth phase. In radial growth phase, it is the initial phase of the growth of the tumor. So there is two phases. One is radial growth phase and another one is vertical growth phase. So the radial growth phase, it is the initial phase of the growth of the trauma, and neoplastic cells are shed with normally maturing epithelial cells, and although some neoplastic cells, and these are penetrate the basement membrane. So they are destroyed by a host cell immunological response. So in radial growth phase, we have to remember it is the neoplastic are shed with normally maturing epithelial cells, although some neoplastic cells may actually penetrate the basement membrane also. In vertical growth phase begins when neoplastic cells populate the underlying dermis. It is called vertical growth phase. So this takes place because of increased virulence of the neoplastic cells, decreased host cell response, or both. So here the metastasis is possible. So in vertical growth phase, the metastasis is possible. Next, moving on to the clinical features. So according to clinical features, malignant melanoma is having different types. The first one is superficial spreading melanoma. It is the most common cutaneous melanoma in Caucasians, and it is nearly 65% of the cutaneous melanoma. It exists in a radial growth phase. So it is called as pre-malignant melanosis or pagitoid melanoma in situ. So it is called as pre-malignant melanosis or pagitoid melanoma in situ. So the second one is nodular melanoma, and it is 13% of cutaneous melanoma and has no clinically recognizable radial growth phase, and it is existing solely in a vertical growth phase. So nodular melanoma occurring in the vertical growth phase. It presents as sharply delineated nodule with varying degrees of pigmentation. The color is pink or black in color. And the third one is lentigo maligna melanoma, and 10%. It is exist in radial growth phase. It is known as lentigo maligna or melanotic freckle of Hutchinson. So the lesions occurs in macular lesion on the malar skin of the middle-aged and elderly Caucasians. So superficial spreading melanoma, it is occur in radial growth phase, and nodular melanoma, it is occur in only in vertical growth phase, and lentigo maligno melanoma exist in radial growth phase. And the fourth one is acral lentiginous melanoma. So it is a developing on the palms and soles as well as on the toes and fingers, and the tumor is macular lentiginous pigmented area around the nodule. So mechanical stress may lead to erosion and ulceration, rapid progression from radial to vertical growth phase. So in acral lentiginous melanoma, the lesions start at the radial growth phase 2 and end with the vertical growth phase. And the fifth one is mucosal lentiginous melanoma, developed from mucosal epithelium that lines the respiratory, gastrointestinal tract, and genitourinary systems. It is present as 3%, and it is found in any mucosal surfaces, including conjunctiva, oral cavity, esophagus, vagina, female urethra, penis, and anus. And non-cutaneous melanoma are commonly diagnosed in patients of advanced age. And the sixth one is melanotic amelanotic melanoma, present as an erythematous or pink, sometimes eroded and nodule. This tumor is often confused for other tumors, and only the histological examination provides the right diagnosis. This is the sixth type of malignant melanoma, that is amelanotic melanoma. So next, moving on to what are the clinical diagnosis criteria for clinical diagnosis of melanoma. The ABCDE rule is followed. In here, the A is asymmetry, that is in which one half does not match the other half. So asymmetry in which one half does not match the other half. And the second one is B, border irregularity. The border is with blurred, notched, or ragged edges. So border irregularity is seen in the malignant melanoma. And the C, and the third one is C. C means color irregularity. That is, pigmentation is not uniform, brown, black, tan, red, white, and blue color. So it can all appear in melanoma. So D is diameter, it is greater than 6 mm, and growth in itself is also a sign. And the E for elevation, it is a raised surface, can also be a sign. So A is asymmetry, B is border irregularity, and C is color irregularity, and the D is diameter, and E is elevation. Next, moving on to oral manifestations. It is uncommon neoplasm of the oral mucosa, and it is more common in the men compared to women, and it is the overall age of occurrence is approximately 55 years, and between ages 40 to 70 years. The oral melanoma exhibited definite predilection for the palate and maxillary gingiva or alveolar ridge. Cases also recorded on the buccal mucosa, mandibular gingiva, tongue, lips, and floor of the mouth. The lesion usually appears as a deeply pigmented area, at times ulcerated and hemorrhagic, which tends to increase progressively in size. So, oral manifestations, deeply pigmented area, at times it get ulcerated and hemorrhagic. So this picture showing the malignant melanoma that is involving the labial, maxillary labial mucosa and gingiva. And this picture showing the malignant melanoma that involving the palatal, anterior palatal region. So what are the differential diagnoses for melanoma? The first one is seborrheic keratosis. The distinguishing characteristics of seborrheic keratosis is stuck-on appearance, and it is symmetric and often multiple. The next one is traumatized or irritated nevus. It is turns to normal appearance within 7 to 14 days. And lentigo, it is prevalent in sun-exposed skin and evenly pigmented and symmetric. And angiokeratoma, it is vascular tumors, difficult to distinguish. And venous lake, it is blue, compressible and found on ears and lips. And hemangioma, it is compressible and stable. And dermatofibroma, it is firm growth of fibrous histocytes, that is buttonhole when pinched. And pigmented actinic keratosis, it is sandpapery feel and sun exposed area. And pigmented basal cell carcinoma, it has waxy appearance and telangiectasis. These are the differential diagnoses for melanoma. Next, moving on to histological features. So the malignant cell often nest or cluster in groups in an organoid fashion. However, single cells can predominate. So the melanoma cells have large nuclei, often with prominent nucleoli. So it is a large nuclei that is prominent. It has prominent nucleoli, and it is show nuclear pseudo inclusions due to nuclear membrane irregularity. And there is abundant cytoplasm may be uniformly eosinophilic or optically clear. And occasionally the cells become spindled or neurotized in areas. So this finding is interpreted as a more aggressive feature compared with findings of the round or polygonal cell varieties. So here the cells are large cells, and there is a large nucleoli and the nuclei, and it has a prominent nucleoli. So the first type is superficial spreading melanoma. It presents of large epithelioid melanocytes distributed in so-called pagetoid manner, and it is called as buckshot scatter. So this pagetoid spread within the epidermis is sometimes known as buckshot scatter. So the melanocytes penetrate basement membrane. Florid host cell response of lymphocytes develops. So macrophages and melanocytes may be present. It has vertical growth phase, that is a proliferation of malignant epithelioid melanocytes in the underlying connective tissue. These are the histological features for superficial spreading melanoma type. So it has radial growth phase. Here the important point is buckshot scatter or pagetoid manner. And the second type is nodular melanoma. It is also characterized by large epithelioid melanocytes within the connective tissue. There is a small ovoid and spindle shaped cells also present. Tumor cells may invade and ulcerate the overlying epithelium, and it penetrates the deep soft tissues. These are the histological features for nodular melanoma. So nodular melanoma, it is a large epithelioid melanocyte within the connective tissue. And the third type is lentigo maligna. It is also called as melanotic freckle of Hutchinson. So melanotic freckle of Hutchinson is lentigo maligna. Has well-defined histological features which have been discussed by Waite and Helwig. So what are the histological features? There is an increased number of atypical melanocytes within the basal epithelial layer, and the epithelium is generally atrophic, and the dermal collagen show the effect of sun damage, that is basophilic degeneration is present in lentigo maligna. And the fourth one is acral lentiginous melanoma. Is histologically similar to lentigo maligna melanoma. So what are the histological feature? Is lentiginous radial growth phase and deep vertical growth phase composed predominantly of spindle shaped cells, and psoriasiform epidermal hyperplasia, and intense host cell response, and a prominent desmoplasia associated with the vertical growth phase. These are the histological features of acral lentiginous melanoma. So this picture showing the cutaneous melanoma. This is also the example of cutaneous melanoma. What are the treatment? So the treatment of cutaneous malignant melanoma is a surgical excision, although a regional lymph node dissection is indicated when the nodes are involved. So tumors, if it is more than 0.75 mm in thickness and located in the so-called bones, that is back, arm, neck and scalp, sites have a greater tendency to metastasis. So, and the treatment of other modalities or chemotherapy, immunotherapy and radiation therapy have been used in the treatment of cutaneous melanoma. So the treatment of oral melanoma has been still is surgical excision. And what are the prognosis? If it is level 1, that is tumor in situ, tumor is confined to the epidermis and is entirely above the basement membrane, then 100 to 98% prognosis is good. And level 2 is invasive cells are only present in the papillary dermis and the tumor is usually still considered to be in the radial growth phase, then prognosis is 96 to 72%. And level 3, the tumor cells are found throughout the papillary dermis with impigmented on the reticular dermis. The tumor has entered the vertical growth phase, then it is 90 to 46. And the level 4 is tumor cells are clearly seen between the collagen bundles of the reticular dermis, that is 6